Sophie. I am the Advocacy Officer at Leukemia Care, and I will be chairing today. And I'm being joined by a couple of lovely speakers who I will introduce to you shortly. But I'll just start by introducing the topic today. So this webinar is all about hairy cell leukemia today, and we're going to have a chat about what it is and how it's diagnosed and treated, and also a bit more about the support that you can get if you do have this diagnosis, and things like what your nurse can do to support you through this. And this is a webinar that is directed at anyone affected by HCL. So whether you're a patient yourself or if you're a family member or a friend, then hopefully you'll be able to take something away from today that you'll find helpful. So we are live on Zoom and also on Facebook. So we will have a couple of presentations and then we will go into a Q&A session. So if you have any questions throughout and you're on Zoom, then put them in the chat. And if you're on Facebook, then pop them in the comments. And a couple of my colleagues will be monitoring that and they will be sent straight over to me to have a look at. Right, okay, so I will introduce you to our speakers today. So I've got Donna here. Donna, if you'd like to introduce yourself.
Hi, my name's Donna and I am one of the lymphoma clinical nurse specialists based at the Royal Marsden.
Thank you, Donna. And Dima.
Hello everyone, I'm Dima Sharkawi. I'm a haematology consultant at the Royal Marsden Hospital, where I treat lymphoma, CLL and hairy cell leukemia.
Oh, brilliant. Thank you, Dima. And it's so nice to have both of you here today. So with that, I will pass straight over to you, Dima, and you can get straight into your presentation. Thank you.
Thank you very much, Sophie. Now bear with me whilst I get the presentation up. But hopefully now, Sophie, before you disappear, you can just confirm that it is sharing, okay?
Yes, it's on there.
Excellent. So this is very much a basic talk for those that perhaps are newly diagnosed or haven't really thought about their condition before. As I've said, I work at the Royal Marsden Hospital, and this is about hairy cell leukemia. So first of all, what do we mean by when we say hairy cell leukemia? And I thought that it would be useful to break this down for you all and to just understand a bit of basic hematology, because it makes understanding the process a lot easier later on. So hairy cell leukemia is a cancer of your B lymphocyte. So I'm going to break this sentence down for you. And first of all, let's explain what B lymphocytes actually are. So this is like the tree of life for hematologists. So you produce all your blood cells in the middle of your big bones, in your bone marrow. And in your bone marrow, you have stem cells that have the ability to become any of your blood cells. So those stem cells can divide, and then they can also differentiate into the different blood cells that everybody has. So how they differentiate is that either they can go down the myeloid route or the lymphoid route. Down the myeloid route, these cells eventually become red blood cells, platelets, and some of your white blood cells called neutrophils or granulocytes, such as eosinophils or basophils. So your red blood cells carry oxygen around the body, the platelets help your blood to clot, and the white cells help fight infection. So that's the myeloid route. The lymphoid route is also part of your white cells that help fight infection, and your lymphocytes can either become B lymphocytes or T lymphocytes, and some of your B lymphocytes can become plasma cells, and they produce antibodies that help fight infection. So as I said, hairy cell leukemia is a cancer of these B lymphocytes. Essentially, any of these cells could become cancerous and become a different blood cancer. And so if you tell people you've got a blood cancer, it could be any one of many, many different diseases. But hairy cell leukemia is a cancer of the B lymphocytes. So we've explained what B lymphocytes are. So why leukemia and what do we mean by cancer? So leukemia is just the Latin, or leuc is the Latin for white, and emia is of the blood. So it's essentially cancer of your blood cells. This is because you get abnormal blood cells in the blood, and they're hairy cells, or that's why the reason that the condition is called hairy cell leukemia is because this is what they look like under the microscope when we're diagnosing them. And you can see that it looks a bit hairy, these cells, whereas normally lymphocytes have a very smooth outline. These have little hairs on end, and that's where it's got its name from. So how does hairy cell leukemia present? So as I said, all your blood cells are produced in the middle of your bone marrow, in the middle of your big bones. And so if you're producing too many hairy cells, it's stopping you producing your normal blood cells. So if you think about that tree I showed you before, if you've got too many hairy cells that your bone marrow is abnormally producing, you're not going to produce enough red cells, and that's what we call anemia. And as I said, red cells help carry oxygen around the body. So when people are anemic, they might present with shortness of breath or tiredness. If your platelets are low, so if you recall, I said platelets help your blood to clot. So then patients with low platelets may present with bleeding or bruising. And then similarly, if your neutrophils, which I don't know how well, it projects on all of your screens, but these white cells that have these funny bits in the middle here, these blobs, are the neutrophils. So as I said, these help fight infections. And so if your neutrophils are low, you might present with an increased number of infections. And so then when your GP or your healthcare practitioner performs a blood test, we might not pick up the hairy cells, but we might pick up that you've got low blood count levels as the initial presenting feature. So there are other features of hairy cell leukemia. So a proportion of you will present with an enlarged spleen, which is quite common in hairy cell leukemia. The spleen is part of your lymphatic system, and so problems that arise in the bone marrow can often also affect the spleen as well. There are what we call paraneoplastic phenomena, which doesn't happen in everyone, but can happen in some patients with hairy cell leukemia. And by that, I mean things that may happen indirectly as a response to the hairy cell leukemia. So some of you may get rashes or skin conditions that are associated with the hairy cell leukemia, allergies, or vasculitic type problems, which are often what we'd consider rheumatological problems. So some people get joint pains or other problems affecting other organs in their body as a result of their hairy cell leukemia. Fatigue is a very common symptom of hairy cell leukemia. As I already said, it can be related to anemia, but sometimes even patients that aren't anemic can be quite fatigued. And that's probably because you've got all these abnormal cells in your body and they require energy to keep them going. And so probably that's possibly one of the reasons why people are fatigued. And similarly, some patients can get quite significant bone pains, again, likely because of the abnormal cells in the bone marrow, but not everyone is going to get all these features. So as with all cancers, the only way to absolutely diagnose it is by biopsy to get the abnormal cells. So some of you may have had their diagnosis made from blood tests, but the majority of you probably ended up having a bone marrow, so taking a sample from the factory where you produce your blood cells. So you probably don't really want to see what's happening behind you when a bone marrow is happening. But this is essentially what we're doing. We're taking a sample from the middle, from the pelvis, and we take a liquid part that looks like blood, but it's your bone marrow, and we can put it onto slides to spread out the cells, to have a look at the cells to see, are you producing any abnormal cells, but also what's happening to your normal cells. And we also can take a biopsy. And this is the way to diagnose hairy cell leukemia. When we have taken the samples, we send them off for different things. So first of all, we can look down the microscope to see those abnormal cells, a bit like the cells I showed you before. Sometimes they're not as obvious as that, because sometimes people can have not many hairy cells in the bone marrow when we pull out the aspirate. So it's not always that there's lots and lots of hairy cells there. So sometimes we do other tests to try and confirm the diagnosis. So this was my predecessor, Dr. Dearden, showing then Prince William quite a few years ago. She was showing him an example of hairy cell leukemia down the microscope so he could see what that looked like. So we look down the microscope, but also we can do special tests on the liquid to see the proteins on the surface of these B lymphocytes. And there's certain characteristic proteins that are typical of hairy cell leukemia that can help differentiate hairy cell leukemia from other cancers that affect B lymphocytes, of which there are many, so many other lymphomas and leukemias. So hairy cell leukemia typically expresses these proteins, the CD25, CD103, 123, and 11C. So that's looking at the proteins on the surface of the cell. But as well as that, more recently, we routinely also check for the genes within the cell. So if this, for example, is a hairy cell, within any cell, you've got your 23 sets of chromosomes. And so we can look to see if the abnormal cells still have the normal number of chromosomes. But as well as that, so that's sometimes called cytogenetics. But as well as that, we can look on the genes that are on the chromosomes. And there's a certain gene called BRAF that is mutated in the abnormal cells in about 90% of patients with hairy cell leukemia. So even kind of maybe 10, 20 years ago, we wouldn't have routinely been checking for these genes to see if they're mutated or not. But now they've become part of our routine panel that can help us not so much diagnose hairy cell leukemia, but more to differentiate it from other lymphoid malignancies, as I say. So, as I said, the BRAF mutation is seen in over 90% of patients with hairy cell leukemia. It's not totally specific, so you can have BRAF mutations in other blood cancers, but that's much, much, much rarer. So as well as this being helpful from a diagnostic perspective, there are some drugs that can target the BRAF enzyme, because every gene, I should say, produces a protein, and this mutation leads to this protein being overactive. And if this protein is overactive in the abnormal hairy cells, it leads to the cell basically continuing to replicate and divide. So whereas most cells will eventually die, the hallmark of cancer cells, if you like, and hairy cell leukemia is no different, is that the cells continue to replicate and divide. And that's partly because the abnormal protein leads to the other proteins in the cells to continue to remain active, leading to tell the cell to keep dividing. So there are some drugs that can help inhibit this enzyme, and they've been shown to be effective in hairy cell leukemia. So this is a rare leukemia. About 200 people are diagnosed with it in the UK every year. So I kind of did a rough back of the envelope kind of calculation to work out what that meant in terms of how often a GP is going to see it. And I think I worked it out roughly to be that for every 200 GPs there are in the UK, they will have between them only one patient with hairy cell leukemia. And I think that's quite a good way of thinking about it, because then you kind of understand why GPs aren't so familiar with the condition and they won't really be able to differentiate or tell you what's different about hairy cell leukemia compared to another leukemia, because they're such rare conditions that they won't know the differences between them. In terms of data that's published, there's quite a skewing towards men. So it seems to be, for reasons we don't know, more frequent in men than women, although we have plenty of women that do have hairy cell leukemia. And the median age at diagnosis is in the mid-50s. So we've got patients that are much younger, and we've also got patients that are much older when they're diagnosed. But the average age at diagnosis is around 54. One of the questions we get asked very frequently is, why me? And we don't know of any risk factors specifically for hairy cell leukemia. So the answer is, we don't know why you. And then the other question we get asked a lot when we see patients initially is, okay, you've told me I've got a cancer, you've told me it's a blood cancer, leukemia sounds very scary, how long have I got? But hairy cell leukemia is very different to some other leukemias. And actually, the survival of the vast majority of patients with hairy cell leukemia is exceedingly good. So you may ask the question, how long have I got? The way we talk about it in medical terms or in scientific terms, or if you start to read medical papers about it, is something called overall survival. And so there are various publications that are out there that have shown that actually when they compare patients who've got hairy cell leukemia with a normal population that are matched for age and sex, that actually this overall survival is the same. So there doesn't seem to be a difference in those that have got hairy cell leukemia, and the survival is just as good as those who don't, which is obviously very encouraging. And then there have been also recent publications looking at very long-term follow-up of quite a large number of patients in centres that also have expertise. And again, both these publications from the last couple of years have shown that the median survival, and by median we mean the number of years that 50% of the population survive to, is 27 years. So, and if you think that actually the median age at diagnosis is 54, that you can see that actually this is probably very similar to, as we say, an age-sex matched population. So, you know, it's not for everybody, won't have such favorable outcomes, but the vast majority of people do very well with hairy cell leukemia, which is obviously very encouraging. So I've told you what it is, what symptoms it might produce, and how we diagnose it. So the next thing is about treatment. So the first thing is there are a few people who will be diagnosed with what we would call very early stage hairy cell leukemia, that yes, we might pick up the clone, but their blood counts aren't so low and they haven't got so many significant symptoms that we might not treat everyone right from the beginning. Now, that can be quite a hard concept to understand because, you know, most of us are all very used to the information we get all the time about treating cancer early, better outcomes with early treatment. But unfortunately, none of the treatment we've got will get rid of the clone completely. Even if we've got plenty of treatments that reduce the number of cells, but if we wait long enough, we know patients will develop the clone again. And so none of these treatments are what we would call curative. And so because of that, sometimes, not in everyone, but sometimes we may not treat patients straight away. And so then we will follow patients up, monitoring for symptoms and monitoring for evidence that their blood count is beginning to drop. And those are the kinds of things that we're looking for to indicate that they might be heading towards needing therapy. So when I say their blood counts are beginning to drop, what I mean is looking at their normal bone marrow function. So like I said, looking at their hemoglobin, are they becoming more anemic? Looking at their platelet count, is that dropping? Looking at the neutrophil counts, is that dropping? So we're not in a way, we're not really that interested in how many of the hairy cells there are. It's more what impact it's having on your normal bone marrow function. So once we've decided when to treat, the next thing is what to treat with. And the majority of you who've had treatment will have probably had either cladribine or pentostatin. So these are two chemotherapy type drugs that essentially affect the way that the cells replicate and prevent them from replicating and kill the hairy cells. And they are very, very effective at doing it. So these are quite old-fashioned drugs that we've been giving for decades now for hairy cell leukemia, but because they do so well, we haven't really needed to move to newer therapies, if you like, for the vast majority of patients with hairy cell leukemia. There are other therapies that we know can be effective, but actually the vast majority of people with hairy cell leukemia won't need any of the other therapies and can probably just have one or two of these. And the other thing that's quite unusual about hairy cell leukemia, which is different to some of the other lymphomas and leukemias that we treat, is that often we can repeat the same treatment again, and it can still be quite effective for a number of years. So I am going to mention a couple of other treatments, because some of you may also get rituximab, which is a more targeted therapy that targets one of the proteins that's on the surface of the B lymphocyte. So we give rituximab to a lot of our B cell lymphomas and leukemias, because it targets B lymphocytes in general. And it has been shown to be effective in combination with chemotherapy, but we don't standardly give the combination together because people often do very well with just the single agent. And then for the few people who eventually become refractory, that their disease no longer responds to one of these treatments, then there are other treatments that are that are used, but they're not licensed specifically for hairy cell leukemia. So they may be used in clinical trials, or we may get access to them through other avenues, but they're not routinely available on the NHS. So like I mentioned, there are inhibitors, so tablets that you can take that inhibit the enzyme that is overactive, BRAF. And there is another enzyme that can be targeted called BTK. And again, although hairy cell leukemia is a very small disease in terms of number of patients getting it, but we know that these enzymes can be abnormal in other cancers. So there are companies that have made targeted tablets that target these enzymes, mainly because they can be used in other cancers, because obviously most pharmaceutical companies make drugs that are going to make them money, and so they will target. So for example, melanoma, also a lot of patients with melanoma, skin cancer, have mutations in BRAF. So some of the BRAF inhibitors have primarily been developed for patients with melanoma, for example, but we've used them in patients with hairy cell leukemia with some success as well. But as I said, the majority of patients will only need cladribine or pentostatin. So if someone's had treatment, how do we assess response to the treatment? So there's assessing response in an individual, and then there's assessing response to see in a clinical trial whether a drug has been useful, whether it should be investigated further. And I think basically for an individual, we'd want to look at all of these things, really. Primarily, we want you to feel better. So if you're getting symptoms related to the hairy cell leukemia and I treat you, I want to see whether the symptoms get better. We can look at the full blood count to see if you were anemic before treatment, has that improved? If you had a low platelet count, has that improved? Has your spleen reduced in size? And then we can also formally assess the burden of the abnormal cells. So to repeat the bone marrow to see, can we still detect the hairy cells? And if so, what percentage of cells are we seeing that are still hairy cells? These treatments can take a long time to have an effect, so we wouldn't rush to repeat the bone marrow, and we wouldn't do it until about 6 months following treatment to assess formally the burden of disease. Again, if you look at trials to assess response, then they will also look at depth of response to see how good a response you've had, so that you will see in clinical papers they will talk about complete response and partial response. And again, they'll be looking at the same kinds of things. So for a complete response, they'll want us to demonstrate that your normal blood count has returned to normal levels or near normal levels, that you've had a clinical response, and that your bone marrow, we can't pick up any hairy cells. Whereas a partial response is that you might still pick up some hairy cells, but there's been a reduction. So that's kind of looking at the depth of response, but also quite importantly in clinical trials, we'll want to see how long a response lasts for. And so one of the things that we've looked at in the past, as some of my predecessors has looked at in the past, is to see whether we're better off using cladribine or pentostatin in our patients. And so you will often see these survival curves in publications. So I'll spend a bit of time explaining them to you so that you can understand them going forwards. So as you can imagine, when people start trials, not everyone's starting the drug at exactly the same time. So we create these survival curves to account for the fact that people are going to have been followed up for different lengths of time. On the x-axis, you're going to have the number of years since the start of treatment. So some people may have been followed up for 4 years, whereas others are going to have been followed up for 16 years, 18 years. And on the y-axis, you're going to have whatever event we're looking at. And here we're looking at the percentage of patients that are progression-free, that their disease hasn't progressed since the start. So as you can imagine, when everyone started the drug, 100% of people haven't progressed. But over time, when people's hairy cell comes back, we'll see this number drop. So say at 5 years, after after starting therapy, we'll see approximately 70% of people remain progression-free, that their disease is still in remission with the cladribine. So that's essentially what it is. And it allows for different lengths of follow-up, essentially. But what we saw was that there was no significant difference between those that had pentostatin compared to those that had cladribine, that actually these curves were fairly similar. What we did see, and what has been seen in other studies as well, is that the depth of response did correlate with the progression-free survival. So those that achieved whatever they had, whether it was pentostatin or cladribine, those who achieved a complete response or had that deepest response tended to have a longer time until their disease came back. But that's looking at population level data, whereas, you know, there are going to be individuals who did achieve a complete response whose disease does come back quicker than those that achieve a partial response. So although we can give general assumptions, it's not going to be the same for every individual. So as I've said, repeated treatment can still be effective, but on average will not last as long. So here we've got people that have had pentostatin or cladribine, and this is the first time they have it. The majority of people will achieve that deepest response of complete response. The second time they have it, you know, still a lot of people achieving a complete response, but it's a lower percentage. So maybe about 65% compared to about 80%. And similarly, we might give it for a third time, and fewer people will get a complete response, but you're still looking at about 50% of people, even the third time, getting a complete response. And the median time to relapse, so the time that 50% of the people have relapsed, but 50% of the people are still in remission, is around 16 years the first time you have treatment, 11 years the second time, and 6.5 years the third time. So, you know, it is long time between needing therapies for the majority of patients. And this is just to show in terms of the durability of response, that if you get a complete response, whether it be the first time or the second or third time, that actually the length of time you remain in remission tends to be the same, just as I said, fewer people will be getting a complete response with that second and third line of therapy. But if you do, then the outlook is pretty good. It's not just the disease itself that can be an issue. And as I said, because this is a cancer of one of your immune cells, people can be at increased risk of infections, and vaccinations may not be as effective. And so we do advise that patients avoid live vaccines as well, to avoid potential infection related to that. And so we tend to recommend that people have vaccinations similar to those that we advise patients with other B lymphoid malignancies to have. So, you know, have the flu vaccine each year. You'd be in the extremely vulnerable group with regards to COVID. So we'd recommend all the COVID vaccines that have been advised for that group. And to have the pneumonia vaccine if you haven't had it in the last 5 years. And then the shingles vaccine that we standardly give in the UK is a live vaccine, but there is a non-live version that is now available to patients who can't have live vaccines. So those are recommended. And then the final thing is, obviously, this is a disease that you're going to have or live with for life. So it's not just about managing the disease, but it's more about you learning to live and carry on enjoying your life whilst we manage the disease if and when we need to. So it's kind of continuing your normal life, and this being just a small part of your life rather than changing everything in your life. And we try and support that so you can carry on doing the things that you enjoy doing. And this is where I hand over to Donna, who talks more about this holistic side.
That's brilliant. Thank you, Dima. Yes, so Nick, if you can pull up Donna's slides, that'd be great. Dima, that was really interesting. I think I learned a few things there with that presentation, to be honest. Really good. Great. Right, Donna, over to you whenever you're ready.
Thanks. So hi everyone. So yeah, as I said before, my name's Donna, and I am a clinical nurse specialist, also known as a key worker, and I'm based at the Royal Marsden. We can move to the first slide. So CNS, or clinical nurse specialist, so we act as a key accessible professional. So we're part of the larger multidisciplinary team, but we can be a key point of contact for patients like yourselves, so that you can get in touch with somebody fairly easily. You may have, so we work at our site, we are split into separate malignancies. So my specialty is lymphoma, and our hairy cell patients come under our lymphoma umbrella. But you may have at your centres just a haematology CNS who covers a whole range of haematology. So we work with individual patients, and we can hopefully avoid emergency admissions to A&E, because you can call us with any symptoms that you've got. If we think you need to be seen, we can bring you in, do a blood check. If you need blood product supportive care, we can arrange that. But just often having that point of contact at your hospital prevents you having to go to A&E, which is obviously very helpful. So key worker, CNS, the terms cross over. We generally get to know you very well, because we're there throughout the whole pathway, from diagnosis to surveillance through treatment and beyond. So you get to know your key worker quite well, and we help to coordinate all your care if you need treatment. Next slide. So what sort of things can your key worker or your nurse specialist do? So we have clinical knowledge so that you can contact us if you've got any concerns with symptoms. But we can also refer and signpost to other things that you might need, benefits advice, employment advice. Dima touched on the vaccinations there. We can liaise with your GPs, let them know what vaccinations we're recommending. Letters of support. Now, this can be for various things. I'm just trying to think of some of the examples I've had. People wanting to go to spas, or people wanting to go to events, festivals, or actually as someone who was starting treatments and wanted a refund on a festival ticket, so I did a letter for that. Tattoos is another common one I get. They want letters for tattoos, so that sort of thing. We can also signpost you to psychological support. Now that can be individual, but it's also, you know, your families as well. So Sex and relationship support. We have sex therapists if people are struggling with that with their diagnosis. Relaxation therapies, things like aromatherapy, massage, dietitians we can refer you to if that's needed. And again, as I mentioned, we're kind of with you for the whole journey. So the continuity with your clinical nurse specialist can often be a really important factor for patients, because when you come into clinic, you might not see the same doctor all the time. But generally your clinical nurse specialist will be the same person. So you get that continuity, which is always very helpful, I think. Next slide. So those people that are on active surveillance or watch and wait, or probably better known as watch and worry, because that's obviously what a lot of people do, which is normal. And that's one of the things we can help you with. So you don't know what symptoms are related to your hairy cell and which are not. So we can be your first point of call for that. You're going to think about it all the time, and that's okay. We don't mind you calling or ringing us, emailing us. I've put here that it's crucial that patients can maintain a normal life, and Dima touched on that as well. I think rather than putting normal in capitals, I should have put it in inverted commas, because really what is a normal life? But what's normal for you? What can we do to help you maintain the activities that you were doing prior to diagnosis and keep that normality going for you? And it does get easier over time, but we're here to support you in the interim. Next slide. So as well as supporting you through the difficult period where you might just be under surveillance, you may reach a point where you need treatment. And again, we come in and we assist you with that. So there may be symptoms that you need management with. So if you need, anti-sickness drugs in relation to your treatment, or you need, like I said, blood product support because you're a bit anemic, we can help set all those things up for you. We can help you with the logistics. When your appointments are, where do you have to go? How do you get there? Where is the blood room? Where is the clinic room? That sort of thing. So we're always on the end of the phone or an email to help you with the logistics. If there is ever a time where you're advised to go to A&E, then we will liaise closely with the teams over there, because I think it can be quite scary if you go to another hospital that's not your main centre, and you're worried they don't know anything about me, they don't know about my treatment, they don't know about hairy cell, am I going to get the right treatment that I need? Well, actually, we can link up with them as well and support them so that you get what you need while you're there. As I've mentioned, we give out our phone numbers and email addresses, so we're always happy to give advice, and we just want you to be confident in living with your diagnosis and treatment. Next slide. So I get a lot of, I don't want to disturb you, and I cannot stress enough, it's a huge part of our job. Please disturb us. We are here to help you. If you call us with something and we don't think it's related to your hairy cell, we'll tell you, I don't think this is related, don't worry about it. If we think we need you to be seen sooner, if you're on a surveillance, you might not be being seen for 3 months, 6 months, potentially even longer. In that interim, you are allowed to come back, you are allowed to call us, and if we think that we need to bring your appointment forward, we'll do that for you. So that's just a very brief overview of some of the things that a CNS or a key worker can do for you.
Oh, that's brilliant, Donna, thank you. I think you've covered everything really well there. And it's always good to use your CNS for a bit of everything, really. Okay, brilliant. So we've got about 15 minutes for a Q&A. I've been watching a few questions come in that I've got on my other screen. So I'll try and cover as many as I can. So bear with me. So Dima, I was thinking about on one of your slides, you said that the overall survival for hairy cell leukemia patients is typically around 27 years. So could you say that it's the case that people often die with HCL rather than from it?
Yes, I think that's absolutely right. And you've summed it up, that because, we've seen compared to age, sex populations that it's similar overall survival. So the vast majority of people will die from things completely unrelated to hairy cell leukemia. There is, in those that the few that do die related to hairy cell leukemia, actually it's probably infection may be more of an issue, but again, how much of that is because of hairy cell leukemia, how much of that is because of age and other medical problems, it's difficult to kind of tease everything apart. It is very seldom that patients die from hairy cell leukemia itself. I should say that is classic hairy cell leukemia. There are more aggressive variants of hairy cell where it's slightly more frequent, but the classic hairy cell leukemia, the vast majority of people will die with it, as you say.
Okay, thank you. So I'm just having another look as well, and we were also talking a lot about the diagnosis. Obviously, it's quite a process getting a diagnosis of a hairy cell. So someone has asked, they've mentioned that they're interested to know the role of monocytes in diagnosing hairy cell.
Yeah, so that's an interesting one. And so like I said, you have lots of different white cells that all fight different kinds of infections. And very simplistically, neutrophils fight bacterial infections, your lymphocytes tend to fight viral infections, but you've also got these monocytes. Now, a lot of non-hematologists might ignore the monocytes completely because they're not one of the major white cell fraction, but for reasons that aren't quite clear, it is very typical that patients with hairy cell leukemia have incredibly low monocytes, so sometimes 0. And so when we're looking for other causes of low blood counts, you know, if we were doing our hematology exams and we see that they've got very low monocytes, we would probably put hairy cell leukemia near the top of a cause. So it doesn't help us absolutely diagnose hairy cell leukemia. We still need to see the hairy cells there, but it might point towards it being hairy cell leukemia. And then the other thing is tracking a patient's disease, it can be useful. So sometimes when patients have had treatment and they're doing very well and their blood counts drop, it may be that they've dropped for another reason. So people can be anemic for lots of different reasons. And so if someone's hemoglobin drops and we're trying to work out what the cause is, if we see the monocytes have dropped as well, then it might point to it being more likely to be the hairy cell coming back as opposed to, you know, another cause of anemia.
That's great, thank you. Yeah, and I've just seen one come through as well, just from our last question. So we've spoken about classic HCL, but someone has mentioned what are the other types and how do you know which type of HCL you've got? Is that something that your haematologist would discuss with you?
Yes, they would. And this is where the different genes and genetic information can be useful. But to be honest, yeah, if you've got the BRAF mutated hairy cell and you're responding very well to treatment, the likelihood is that you've got the classic hairy cell leukemia. The hairy cell variant typically does not have the BRAF mutation. So we always think of mutations as being bad, but actually in this context, those that have got the BRAF mutation tend to have a slower paced disease than something called hairy cell variant, and also but that's not absolute. There are other genetic subsets that do tend to be have a more aggressive phenotype, but they're very rare.
Okay, that's great, thank you. I was going to come back to Donna for a second. I know that we've spoken about the role of the CNS and how you can support patients through a diagnosis and also treatment and management. But I think a lot of patients might struggle with some of the uncertainties that come along with a HCL diagnosis. So could you just talk a little bit more about how your CNS can help you with those and some of the things that you can do to support people in that position?
Yeah, of course. So obviously it's going to depend a lot on where they are in their disease. If they're active surveillance, you know, how much disease is on board, how symptomatic are they, that sort of thing. Some people want to know, can I keep working? They might need letters for employers, that sort of thing. So we're always happy to provide those. With treatments, you know, you'll always be seen in clinic with the consultant or a specialist registrar and ourselves. And so we'll be there to support you throughout the process and checking your response and seeing how you're doing. But, you know, plans change and things go up and down, and so patients' needs change. So we're there to kind of be with you every step of the journey, whichever turn it takes. So just with whatever they need, really.
That's great. Yeah, that's brilliant. Yeah, definitely agree with that. It can be really turbulent sometimes dealing with a diagnosis, especially in the beginning as well. And you know, you don't really know how you're going to feel until you get there. So it's good to know you've always got that support.
Yeah. And I think as well, I know leukemia care is a great thing. You have the buddy system. Yes. And linking up with other people who have the same diagnosis and may have gone through similar pathways. CNS can help you do that as well, and that's often really, really helpful.
Yes, definitely. It always helps to talk to someone else who's been through the same thing. I can speak from personal experience there. Brilliant, thank you, Donna. Okay, I just wanted to pop back to you, Dima, and we've had a couple of questions about treatment and things like that. So someone has asked, because we've discussed low blood counts and dropping counts with HCL. So how is it that a low blood count can delay chemotherapy? Why does that happen?
So this becomes a bit tricky then, because basically chemo works by killing rapidly dividing cells. So yes, when you have treatment, we would hope that your blood counts return to normal eventually as we reduce the number of abnormal cells. But equally, the drugs themselves can cause low blood counts. So you can be in a bit of a catch-22 that if someone's midway through their therapy and their blood counts drop, then we don't want to give more chemotherapy that's caused because we're worried about the side effects of the drug. So, you know, if someone's got low blood counts right at the beginning of their treatment, we might be a bit more relaxed about giving the chemotherapy, because what we hope is that by giving the treatment, their blood counts will rise. But midway through, if things suddenly drop, then we might want to delay the treatment or reduce the dose. And it's always about finding that balance between the efficacy, so how effective the drug's being, but also not wanting to cause too much side effects and toxicity. And so sometimes we do have to delay if people have got low blood counts that we think are related to the drugs. And then the other thing that makes that a bit more tricky with hairy cell leukemia is that it can take a long time for us to see an improvement in the blood count. So as I said, you know, the bone marrow, we wouldn't reassess until 6 months afterwards. So it's a slow disease, but also a slow response as well that can make things a bit tricky.
Okay, yeah, very interesting. And with treatments, how do you decide what treatment to use? I know that we've spoken about a few different ones, but is there an MDT involved, a multidisciplinary team involved with making decisions about treatment options?
So in the UK, in the NHS, every patient is discussed in an MDT. So yes, there is. As I said, the two main treatments, cladribine and pentostatin, there's no evidence that one is better than the other. Hospitals will have their own preference as to which one they tend to use first. And, you know, we get a lot of requests for second opinions or asking if this is still okay. And, you know, either one of those I'm very happy with. There is a shortage in the country of pentostatin. So some hospitals that may normally use pentostatin may be moving towards cladribine. We tend to use cladribine anyway, but there's no evidence. So I'd be very happy with either one of those. And similarly, when we repeat them again, sometimes, you know, if patients have had cladribine and then, I don't know, 12 years later, we might give cladribine again. But if then that second response only lasts 3 years, we might go for pentostatin next just to try something different. But there's no hard and fast rules to this. Pentostatin is given through the veins once every 2 weeks, so the total length of time can be longer. Cladribine you can either give through the veins or it can be an injection under the skin, and we tend to give an injection under the skin between Monday and Friday, so 5 doses over a week, so it tends to be over pretty quickly the treatment. But as I said, there's lots of different regimens and there's no evidence one is better than the other. And then in terms of the newer therapies, we tend to reserve those for those patients that we would say are no longer responding to the cladribine and pentostatin.
Okay, yeah, that's helpful, thank you. And in terms of the treatments, I think this is open to yourself or Donna, and obviously most treatments for leukemias do have side effects. So what is available to help patients manage those side effects? Is there anything that they should do in particular to keep track of them? Should they keep their consultant up to date? What's the best thing to do if a patient feels that they're experiencing some side effects from treatment?
So I think, as Donna said, if they're worried about symptoms, then they should ring their CNS or whatever route of contact they've got with their hospital to tell them about new symptoms. There's going to be some that we expect. So, you know, some people do feel sick and they'll probably have anti-sickness drugs and they can take those. But if they're not working, ring us up. We'll be wanting to monitor some of the responses anyway. And by that, actually, the majority of the responses we monitor to begin with are all the side effects. So we'll want to check that the blood counts haven't dropped significantly, that the liver functions okay, kidney functions okay. Obviously, if someone's got a fever or infection, which can happen either as a result of the disease itself or the drugs, then we'd want to know, because we may need to admit patients into hospital to treat them for infection if their immune system is very low, either again from the disease or the drugs that we give.
Brilliant, thank you. Donna, did you want to add anything to that?
No, I think Dima mostly covered it. I know one thing I say to a lot of our patients is, even sometimes when we do expect certain side effects, like it might be nausea or vomiting, and you've gone home with anti-sickness pills, just let us know if those ones aren't working for you. We have a whole pharmacy supply of different ones to try, and sometimes we have to try different drugs on different people to get on top of side effects. So yeah, it's just important to let whoever your point of contact is know what's going on, and then we can help you manage it.
Yeah, definitely agree with that. Thank you. Brilliant. Okay, so we've had a couple of questions as well. I'm just going to finish with this one because it seems to have come up a few times. So we've spoken about the shingles vaccine and other various vaccinations. So something that we've been very aware of in the advocacy and the policy team here was the recent update on the fact that the Shingrix non-live vaccine will be available to over 50s who are immunocompromised from September. So in terms of, I suppose I've got a kind of twofold question. So in terms of access to that, Dima, would that be something that you'd expect patients to come to yourself with, or would they need to speak to their GP about that?
So just to finish on that last question quickly, just because I read the chat as well, there's someone that had sepsis following their treatment. Generally, the sepsis is as a result of the disease, as I say, or the chemo itself, rather than anything else, because it's an infection because of the lowered immune system. So then to go on to shingles, so because of the lowered immune system with the disease and also the drugs that we give, vaccinations are to try and reduce the risk of getting problems. We know as shingles is from the chickenpox virus, and we know that once everyone's had chickenpox, it's one of those viruses that stays dormant in your body. Most of the time, it never causes a problem again, but if people have lowered immune system, it can flare and cause a bout of shingles. And so a good few years ago, the government decided that as people's immune system all gets older, that actually it's good to give it a boost and give a shingles vaccine. And so it offered all people between 70 and 79 the shingles vaccine. But people that had immune compromise anyway couldn't have it because it's a live vaccine. And so then, I think it was a couple of years ago now, the non-live vaccine became available to those who would have otherwise been eligible. So only but for those patients between 70 and 79. Now, some GPs were still giving it to other patients. So we all know patients younger or not between those ages that got the non-live shingles vaccine. But if you were strictly going by the NHS and what they were funding, it was for those between 70 and 79. Exactly as you've said, very, very recently, they have said that they will offer this non-live shingles vaccine to anyone over the age of 50 who's immunocompromised. And I would say anyone that's got hairy cell leukemia, whether it's been treated or not, would fall into that category. So if you're over 50 and have hairy cell leukemia, I think you would be eligible for the non-live shingles vaccine or Shingrix. Now, how GPs pick up those patients, I think it probably is going to fall on the patient to contact the GP rather than wait to be routinely called. When it was an age cutoff, I think most GPs had set alerts on their computer systems to notify anyone once they reach the age of 70. I think because this is more hard for their computer systems to pick up, it may involve you actually going to the GP saying, I'm entitled. We don't do it in the hospital, so it is something that needs to be done at the GP. Sometimes some patients need a letter of support from the hospital, and so you may need to go back to your CNS or doctor to ask for it. Yes, thanks, Donna. But a lot of GPs will do it on the basis of, they will look it up themselves and see that's the case. But that's very new, so not everyone may be aware of that already.
And is it a one-off vaccine, or is it something that needs to be repeated? Do you know?
Oh, now you're testing me. I think it's a course of 2, but it's not repeated. But I was going to say, don't quote me on that, but I think you're recording this, so if I'm wrong, that's
I'll have a look after.
I'm pretty sure it's definitely, it's not repeated, but I think there's more than one in the initial course, I think.
Oh, great. No, that's brilliant, thank you. And I mean, if anyone watching does have any questions about that, then you can email into me and I'll have a look. Cool, brilliant. All right then, well, thank you both so much for joining me on this webinar today. I'm just going to wait for Nick to put my slides on. That's very good. Brilliant, thank you. So yes, again, thank you both for being here today. It's been a really good session. So I'm just going to go through some closing slides now, and it's just a bit more about some of the support available from Leukemia Care, if there's anyone new online, or if anyone just wants to know a bit more about some of the things that we can do. So we have, obviously we have a lot of information sources, we have our webinars like we're doing now, and we also have a wonderful magazine, and we run podcasts, and we also are very active on social media as well. So if you pop us into Google, then you'll see all of that on there from us. You can keep up to date with what we're up to. Next slide, please. So as I mentioned, we have some booklets. These are all free, so you can order them or you can download them online through our shop. So they are worth checking out. They're very helpful, and they're also good to give to friends and family or anyone else who you think might benefit from having a look at those as well. Next slide, please. As I mentioned, our magazine, we are in the middle of writing our magazine at the moment. So yes, we have it 4 times a year. It's very good. It's full of lots of patient stories and also links to our services as well. So we like to show the real life impact of what work we do here. So if you want to subscribe to the magazine, you can do that. We have lots of support services, as I mentioned, and we have the helpline, and we have WhatsApp, which I run. So if you message us on there, then you'll get through to me. We also have virtual support groups, a welfare service and advocacy service, which is between myself and my colleague. And of course, we have our Facebook groups as well, and a counselling fund, because it can be difficult sometimes to deal with a diagnosis like this. So if there is any of that support that you're after, then just give us an email on our support email, which you'll see on this page. We mentioned earlier that we've got a national hairy cell leukemia support group coming up next week. That's at the same time, 6 o'clock, and Dima and Donna will both be there to answer any questions or to have a chat to you guys. So if you do want to come along to that, then please do go online and book in to attend, or give us a call on the helpline as well. Might be a little bit easier sometimes to give us a call. The buddy scheme, yes, Donna mentioned this earlier. So sometimes it just really helps to talk to someone else in a similar position, or you might feel like you want to give someone else that support as well. So if you want to be a buddy, or if you would like some support from a buddy, then just let us know and we will see what we've got, and we'll try and get you linked in with someone. And the advocacy service, that's me. So if anyone, is interested in knowing more about vaccines, or of course looking for a second opinion, anything like that, then just get in touch and I will see what I can do to help you. And also we have our welfare officer, so anything to do benefits or anything financial, then just get in touch and we can get you booked in for an appointment with Lisa to discuss that further. And of course, if anyone wants to do any fundraising for us, then it always helps. We wouldn't be able to deliver any of our services without fundraisers. So there's lots of different things that you can do, as you can see on there. So if you fancy doing anything for us, no matter how much you raise, then we're always so appreciative, and it just allows us to keep doing what we're doing now. And that's about it. So just keep up to date with what we're doing. So you can check us out on Facebook if you're already on there, and also we're on Twitter and Instagram as well. And you can give our helpline a call if you need anything at all, or just pop an email over to one of the team. Great, so that's everything. So I'll let you all go now. I hope everyone enjoyed it, and hopefully we will all catch up again soon. Bye.